Hello and good evening, everybody. We are here again with 4 complex cases, and today we have race against time. So I will just like to welcome you all my delegates or audiences, whomsoever has joined, as well as we have plenty of experts also today because the cases are so complex. So we have invited Murli Mohan sir because one of the case needs expertise in pulmonary hypertension, and very soon Apar and Vimi also will try to join because few of the cases needs transplant expertise. We have Professor Athol Wells, welcome you sir, and today we have got Professor Katrina also. Good evening all. Bhavin sir, Prahlad sir is joining us from Lilavati Hospital. So I think with this brief introduction, Rajan sir, you want to say something or I will just share my screen?
I'm fine. Okay, I can just start off.
Yeah. Welcome, Dr. Vimal Raj. Also, it is so nice that you could join us. Thank you so much. So I'll just
Will you share the PPT or should I do it, Asmita?
I am sharing my screen and
super.
These are your cases. I suppose it will be seen.
No, that's Madhu's case.
Is it?
Yeah, that's my case. Yeah.
Yeah, 1 second. This is mine. So this is your cases. Yep. Yeah,
we can go to case 1.
Yeah.
Case 1, and this lady is a 45-year-old female jeweler, never smoker, father diagnosed with what seemed to be IPAF at the age of died of IPAF at age of 72, but was diagnosed at 60. And he was seen in the later years of his interstitial disease by a respiratory physician. 2 paternal uncles died of fibrotic ILD. She was fit and well till 2017 when she had her first child. She complained of breathlessness when in Dubai in 2017. A CT was done when she came back to Mumbai and diagnosed as HP. There was no obvious exposure except to birds in general. No autoimmune history. She was not someone who was feeding birds per se. She didn't want any treatment due to the fear of side effects of immunosuppressive therapy till May 2023. She just said, it's okay. I just don't want to take any treatment because I saw my father die on steroids at the age of 72. So I'm terrified. She tried MMF, which I prescribed her last year for a month, but was intolerant. Her symptoms are cough and occasional dyspnea, fatigue at times, not always. She's very anxious, and for that she's on sertraline. Because of the worry of the psychiatrist and myself of sertraline-induced ILD, the psychiatrist switched her to escitalopram 8 months ago. She has bilateral inspiratory squeaks, CCP antibody negative, ANA, ENA screens negative, mildly positive rheumatoid factor and anti-EJ antibody, at a very weak MDA5 positivity. Multiple avian precipitants, IgG positive when she was seen once in London. That was tested. She was advised prednisolone exactly a year ago when she was reviewed in London for her ILD. She declined prednisolone. Next slide. And so the diagnosis was, I can give you the lung function before Bhavin puts up, the scans. This is her lung function since 2017, when she was first diagnosed with HP by me on CT. And so she's remained, as you can see, relatively stable despite no treatment. She's dipped now a month ago. Her DLCO has been above 50% most of the time. She doesn't desaturate much on walk. She exercises. Her echo is normal. She is anxious. And now we have 3 scans. Yeah. Bhavin?
Dear Susie, could I ask you something?
all DLCOs are around 50 or 55. There is one value about 80.
Yes.
Is that correct? Why?
It could be incorrect. Yeah, that could be incorrect,
okay.
I think,
Okay,
Katrina.
okay.
Yeah, I think that DLCO is incorrect.
Okay, thank you.
Okay, so you can see these images, right? And this is the 2017 scan.
Yeah.
Some juxtapleural nodules in the apices, nothing much in the upper and mid zones as we go down and we scroll. She has this platyspondyly with a little bit of a pes, carinatum, excavatum, that kind of a abnormality. And then she had these reticular opacities in the lung bases, reasonably symmetric. The prone images showed that they were there. And this was called, indeterminate, but clinically the diagnosis was HP. So we said it's consistent or compatible with if clinically that works. And then the patient comes back in 23. So that's 4 years later. The upper and mid zones are fine, but you can see very subtle reticular opacities now in the non-dependent segments. And these reticular opacities have increased. You've got new lesions in the superior segments, a little bit of this bronchocentric ground glass here. And as we go further down, again, we see some areas of bronchocentric ground glass, and then these basal reticular opacities. And then when we look at 2024, and we just start here, there is no change between 24 and 23. So if I just scroll all of them together, then you can see that there was progression between 23 and between 17 and 23, but no significant change between 24 and 23.
Yeah, thanks, Bhavin. And so my questions quickly were, Asmita, yeah, I think where I've started her on azathioprine now, because I did tell her that there seems to be, if you don't want to take steroids, at least we should give you some immunomodulation. And we've got it up to 50 milligrams BID now for the last 2 weeks. I've asked her to repeat immunology profiles. A genetic workup at Brompton was negative. You're right, Bhavin. Even Anand Devrajan at Brompton said this was indeterminate for UIP. So my questions were, should I consider a short course of prednisolone at all? And she's terrified of her father's illness and decline, albeit after 12 years from his diagnosis while on steroids, and hence wants to avoid steroids. So should we just keep watching her? That's my questions. These are my questions.
Either Professor Wells or Katrina, please go ahead. No issues.
Professor Wells, would you like to?
You are muted, sir.
Okay. Look, I think
it always comes last, right? So, I think Katrina should go first.
No, okay. Katrina, you go.
Okay, okay, my pleasure. I think that I wouldn't go for the steroids, as also I can, I think patients' needs are very, very important, and there is no particular risk, benefit for her at that time. As our radiologist stressed, there is no difference in the 12-month period between the CT. Even I could distinguish a little bit more fibrotic disease than before. And to be honest, I think that the last scan was much better fit with the DLCO. While the first one does not, it is very, very mild, according to me. I don't know if we have BAL. I think that you do very well with the genetic test and the other screening you requested. I would keep ASA and I would closer monitoring her with PFTs. And in case of a deterioration after 6 months, I would consider antifibrotic treatment on the top of ASA.
Okay. Thank you.
Prahlad, sir. Yeah,
Prahlad,
Prahlad, sir.
I was trying to work out what the really important bit of information is, and to me, it's about 2 uncles and father dying of pulmonary fibrosis. So this is familial pulmonary fibrosis, and we know that in families, some people will get HP, some people will get IPF, you can even have sarcoid. And I'm stressing that rather than focusing on having to call it HP. Because the moment you know that, even if you haven't got a genetic abnormality, you're more worried that over-immunosuppression may create trouble. And what we're seeing here is a slow progression in somebody with a very strong family history, where whatever trigger comes along is likely to provoke an exaggerated reaction. So I'm not bothered you can't find a trigger, because I think a very low-grade trigger could produce HP. You've got inspiratory squawks, and I understand the CT is compatible, no more than that. But for management, it's about the familial bit. Yeah. And I'm not sure a short course of steroid in somebody that's moved slowly for 7 years is actually going to add to management. And I'm a bit concerned about an overuse of immunosuppression. So I guess that we don't know. She might be entering a more aggressive phase, and the FVC raises that question. And you might be introducing antifibrotic therapy very quickly. I suppose if there is really a significant inflammatory flare, you might have to do something with steroids to switch it off, but I wouldn't be doing it just on the FVC. And I would have in mind very early discussion of transplant. Now, she might end up being somebody that actually moves slowly for 20 years. But experience with familial pulmonary fibrosis suggests that this could take off, become devastating, and I'm just worried about too much immunosuppression and antifibrotics not early enough. That'll do from me, won't it?
Sure. No, thank you. Very, very useful comments, Athol. Prahlad, any other thoughts here?
No, I feel her age is 45, right?
Age is 45.
Yeah. If you see this at the age of 45, she has the disease, okay, which is, though it is non-progressive, okay, with the background of a strong family history, I feel though monitoring is good, I'm not saying that, but we have to act at this stage, I feel, in 2024, because though the disease is stable, I would certainly think about putting the patient on low dose of steroids. Okay, I know that because there's an inflammation, there's not much of fibrosis, but her lung functions are, considering the radiological manifestation, physiological disturbances are very much. So why not put a small dose of prednisolone and see the response? Though it is not acute, I understand you could have an acute worsening, would have certainly it has helped. But a small dose of considering her age, a small dose of Vicelon and mycophenolate, probably.
No, she can't tolerate mycophenolate, Prahlad. And, Peter George at the Brompton saw her a year ago and suggested prednisolone like you did. She didn't want to take it. She has a very strong view on steroid. But, I will convince her if the group feels it's the case. Athol doesn't seem to be inclined. That's why I brought the case in. Yes, Athol?
She may owe her stability to the fact that she hasn't had a lot of immunosuppression.
Okay.
Sadly, in familial pulmonary fibrosis, whatever diagnosis you have does much worse than sporadic cases. So HP that's sporadic has a much better outcome than HP with familial pulmonary fibrosis. So my argument would be for introducing an antifibrotic drug now. And I think that just on an FVC in isolation, taking aboard that she's been so stable, and it happens that she's hardly had any immunosuppression, and she might owe her stability to that fact. Right. I think there's enough worry in familial disease about immunosuppression. Okay. And here's somebody with very little immunosuppression who actually hasn't worsened very, very much over 7 years. I would take the appearance of fibrosis that Bhavin points out as an argument for antifibrotic therapy. And I would then monitor and just think about the phenotype that develops. And you might be driven to some immunosuppression, but I would need my arm twisted.
Sure. It's very, very interesting
Yeah,
what you say.
Murli
I'll
sir.
have a chat with
Murli
the...
sir.
Yeah, Murli, please.
Unmute, sir. Can you please unmute yourself?
I largely agree with Professor Wells. Two things. She's still got a lot of ground glass. And if you plan to start her on an antifibrotic, I think combining it with a steroid or short course may be helpful. I would not start her on an antifibrotic at this stage, but I would monitor very closely with all lung functions. And if she's worsening, then dive in with an antifibrotic. But I think along with that, a small dose of steroids or a dose of steroids, I wouldn't say small dose,
Right.
an effective dose of steroids to see what we can reverse, and the antifibrotic for prevented worsening.
No, thanks. That's brilliant, because that's exactly what I wanted to understand, get my head around that familial part and just understand how. I think close monitoring is what I'm going to do. I'm going to talk to her about antifibrotics. She's young. She's very anxious. So we'll get that done. Thank you so much. Super comments there, really. Can we do the next one?
Yeah, I'll just share my screen again. Yeah.
Yeah, so this is an even more difficult lady. She's 48 years old and she's married with 3 children. The eldest is 19, never smoker. She has breathlessness on climbing stairs since August 2023. No cough, no autoimmune symptoms, oligomenorrhea since 2 years, probably perimenopausal. Mother and 1 daughter had TB in the past. No family history of ILD or pneumothorax. She has alopecia for the past 10 years. Ultrasound abdomen, left renal scars, atrophic left ovary, ANA 1 in 80, ANCA, MPO turned in positive last year. PCNA on the myositis antibody profile was weakly positive, PR3 negative. Fresh tests are largely negative. We repeated them now. They're largely negative. We did a VEGF-D level on her, which gives you a clue as to what the scans are going to look like. It was normal. And she's significantly deteriorated in the past 3 months, tires on even 20 steps, very breathless. And I've really no clue what to do with her at this point of time. And that's why I brought her to MDD. The lung functions, you can see when I saw her first 9 months ago, 1.21, very low lung function. She's probably been tolerating this for a long time without complaining. There is a little airflow obstruction, as you can see. Total lung capacity was low, but the RV was high. The ratios were on the border of 70. DLC was very low. She was reasonably well preserved in August last year, but in the last 3 months, she's really declined. And that's why I got a CT done 2 weeks ago, which Bhavin has. And we have the questions. I think you put up the scans and then I can ask you my questions.
Sir, you muted?
2 scans. First is of August 23. The second is April 24. If you look at the August 23, and I'll scroll from top to bottom, clearly we've got a whole bunch of thin-walled cysts of varying sizes. At some places, you can see they're perivascular. The intervening lung is abnormal. We see some septal thickening. We see ground glass. We don't see clear reticular opacities. The cysts also have an upper and mid-zone predominance. The basal regions seem to be relatively spare. So if you look at your common cystic lung diseases, she's not a smoker, so PLCH is kind of out. We don't have the classic presentation for Birt-Hogg-Dubé, and that the intervening lung would be normal. LAM is also unlikely, and VEGF levels have already been done, and those are also normal. And so then we're left with things like lymphoid interstitial pneumonia and other possibilities. If we come to the next scan, which is now done about 6 months later, and I'll just run through that again, there's no significant change. So I will show all, so both of them together. Sorry, let me get this out of the way. So anyway, but when we just look at it together, there's basically that's it. So there's no significant change between the two scans as far as the anatomy and the morphology of the lesions are concerned.
So it hasn't increased, you're saying?
It hasn't increased, no.
Yeah, so I thought, yes, this is unlikely LAM. So should we consider, now she's hypoxic at rest. So should we consider any empirical treatment like admit and pulse with steroid? I can't think of a VATS biopsy. She's really high risk. FLC and gene mutation studies are not easily available in Mumbai. I don't know if it'll change management. And I guess transplant counseling, but I don't think she'll be able to afford it because it's all in private care here. Prahlad, you want to start?
1 second, I'll stop my share. Yeah.
So I feel this is a cystic lung disease, okay, of unknown etiology probably. No LAM, no.
Little louder, Prahlad.
It's more of a cystic lung disease with the the in between lung also looks to be little disease, not like classical like you can say LAM or so. Our treatment in this condition will be a supportive. I don't think steroids has got a role to play here. Okay, so it will be a supportive line of care, and also try to work up for transplant if possible. Otherwise, I don't know whether she's fit for a biopsy. With 2024, the oxygen levels are low, I feel, and the diffusion is so low that getting a VAT lung biopsy will be very difficult. So that is also unlikely. So only supportive, and if possible, get transplant. That should be, we should think about it. So no empiric therapy over here, I feel.
Murli?
The autoimmune flavor is very striking here, so that worries me, and I'm wondering if we are denying her the benefit of treatment for LIP using something. So I would probably start her off on steroids, see how she does. Of course, I think she is headed towards the transplant, so I'd start, you can start crowdfunding for her to try and get some money for transplant. I think she's headed there, but I would give her a trial of steroids and an immunomodulator sooner or later.
Sure. Athol, Katrina?
I think that I very much agree with our colleagues in the panel. I would also see that there is somewhere this flavor of autoimmune disease. I don't know how to call it. So I would try a short course of steroids. I don't think it will harm her, and possibly it will be beneficial for her. Of course, I would consider the lung transplantation and try to help this opportunity, to pursue this opportunity, even only private. And regarding LAM, I think fits very well with everything. However, maybe I would, of course, the levels are low of VEGF. However, I would like Athol's opinion about that, because if this is a possibility, maybe the patient should be treated differently. So this would change our approach.
I think
a difficult case. Yes,
it's difficult.
Yes.
I'm veering towards steroids, whether to admit her and pulse her or give her just prednisone.
I would go with pulses in order to go at the top of her function, and then I would use these pulses in order to down step the steroids in a easier, with a more friendly and very well beneficial approach for her, because we can use lower doses if we pulse. And of course, the patient is feeling very much better, spirometry and also physically. So this is also, let's say, acts beneficial with a lower dose afterwards.
Excellent. I'll give you a follow-up on this. Athol,
yes,
you've had 3 people talk. Athol, your view?
It's quite nice because I can summarize consensus quite neatly. Whatever this is unusual. Let's agree on that. Therefore, if you're going to make a working diagnosis, you've got to accept people saying, I don't like it because of A, B, and C. Whatever this is, it's unusual. I can't diagnose LAM here. The lung function profile is not strikingly obstructive, and I would expect striking airflow obstruction if this was LAM, and the VEGF as well. So I would take that off the table. And I think it's useful in a case like this to ask a simple question. It's again being wise rather than clever. How could I mess up management? And how I could mess up management is that this is LIP and it's not being treated. And I like LIP because, as Bhavin points out, there is this intervening ground glass interstitial abnormality. And I realize that you're supposed to have rheumatoid or Sjögren's to be calling LIP, but I've seen enough idiopathic cases not to go with that. This is unusual, whatever it is, so I want to diagnose LIP. The major error would be to fail to treat that. I agree that high-risk biopsy should not be performed, but to mess the management up would be to fail to go for a definitive response. And I would treat definitively, define the therapeutic gain, and then find the minimal maintenance dose that preserves the gain. That's enough from me, I think.
Yeah, I would like to add, because I'm seeing the audience side questions, there is Dr. Ashwati from Bhubaneswar who has put a question about anti-MPO positive. So was it vasculitis associated ILD? And one more question, almost similar ground, was from Dr. Rikin from Hyderabad. And if there is no anatomical deterioration of the lung, was 2D echo taken, or was there a pulmonary arterial hypertension of any cause causing dyspnea? And maybe it is pulmonary thromboembolism. That is what his thought process is. Another person is it GPA? So Dr. Jyoti, I think you missed the slides, or I would just scroll through it again. I think he has shown that there was a MPO positive, and ANA was borderline 1:80. Madam, if you can comment, is it significant?
See, this low titer ANA, can you hear me?
Yes, we can.
Yeah, this low titer ANA positivity is very many times seen in all these ILDs and all that, but that may not be significant. But the MPO positivity here, especially with this kind of rapidly progressive disease, definitely I think there was some scarring of the kidneys, if I remember correct.
Yes, the left renal kidney was slightly scarred,
Yeah, so I do not know what that means, whether it has been a childhood recurrent UTI or a reflux or something. Because vasculitis per se does not produce these kind of scars.
Sure.
So, I mean, I do not think significantly that we could say that is due to vasculitis, but because of this anti-MPO positivity and this rapid progression, I think steroids and something strong, some immunosuppressant would definitely be worth a try.
Yep. I will do that. I think I've
do we have eosinophilia in the blood? Eosinophilia in the blood?
No, Katrina. I looked for that. No, there's no eosinophilia there.
I would.
Yeah, go ahead.
Sorry.
I wouldn't be distracted by vasculitis. I've not really seen this. I mean, Bhavin can comment, but I haven't seen the cystic phenotype in vascular disease. You do see weird emphysematoid destruction sometimes, but it doesn't look like this. And I think if you've got immune dysregulation and you're diagnosing LIP, I wouldn't be surprised if this or that autoantibody was also elevated. And you are covering that with your management.
Yeah.
So I was wondering if the background also shows some emphysematous changes. I'd like Bhavin and Vimal to comment on that.
There wasn't emphysema. It's just cystic lung disease with an interstitial component.
No, I meant in between the cysts. There were some areas which looked like they didn't have walls, looked practically emphysematous.
Let me get
just a quick glimpse of it. That's also.
This is the second case, isn't it? Oh, here we go. Here's where we are. So if you look at all of these, right, even the ones in the interim, each one of them has a wall. We did look for that, because sometimes you want to know whether there's emphysema or not. But if you see, each and every one of these has a subtle wall or it's perivascular or something like that. So I don't
So some
particularly.
of these areas in between is what I was referring to.
That can be in between. So you look at all of these in between areas as well.
Okay.
They all have, so if I blow it up, you can see that they all have subtle walls. So unlike the centrilobular emphysema, right, where you would, and I get what you're saying, because it may help with, I guess, management more than anything else. It's just that if they're very tiny, now if you were to take something like, this little black hole, you won't see the wall because the cyst itself is very small. But that would, at least I wouldn't call it centrilobular emphysema at this stage. And then funnily, as you go towards the lower lobes, the intensity reduces. Now here we do have increased lucency, paucity of vessels, the air trapping on the expiratory images. So that part exists. If you were to only see the lower lobes, you might even say, are we dealing with hypersensitivity pneumonitis because you've got an airway component? But that's airway component. That's not emphysema. So
Thank you.
That's great. Yeah.
Okay.
She also had a little rhinitis, and just put her on nasal steroids at the last meeting. But we got a sinus scan done. Nothing remarkable there, really.
There are a few more questions. PCNA positivity, is it SLE? If Jyoti madam can quickly. HIV was negative, I believe, Rajan sir.
Yeah, HIV is negative.
So PCP also is not required. PCNA positivity with ANA of 1:80 is not significant,
No,
I
I
believe,
don't think
correct?
we need to take it as significant because she'd never had any other features to suggest lupus.
Yeah.
Sure. So
Only
I
there
will.
is this alopecia. I don't know how much to read into her alopecia, which is.
But
which
we've
is
been having it for the past many years, I think.
Correct. Yeah.
Yeah. So if panel allows me, can I move on to the third case with Madhu sir's case? Yeah. Okay.
So what is the final decision on that?
So I think, Prahlad, my final decision, as the next slides come up, is to probably give her immunosuppression. Prahlad, just put her on steroids and counsel her about transplant if she doesn't respond to steroids, because there's nothing else we can do then. And think of it as an idiopathic LIP with those vascular elements in the cysts, perivascular vessels in the borders of the cyst. Yeah. So I think I should give her immunosuppression. I was almost going to do it, but then I said, let's get her to MDD. She's on oxygen at home and she's happy to do whatever we advise,
What form of immunosuppression you will try?
I was thinking of 500 mg of pulse methylprednisolone for 3 days, get her into the hospital and do that. What do you think, Prahlad?
I think I just thinking digital loudly. I don't know, but we have seen this recently. Few P-ANCA positive vasculitis with interstitial lung disease, and instead of mycophenolate and methylprednisolone, we give some medium dose of steroid, and we consider rituximab or immunologist over here, and we have got a good benefit with this therapy.
Yeah, but we'll have to first see the steroid response.
Yeah,
Prahlad, what do you think?
Absolutely.
Yeah. Before we get on to all that, I agree with you. I probably then get the rheumatologist in when she's admitted, and get a look.
I would also.
I thought you were saying something. I thought.
Yeah, I would say it's critical to establish that this is partially responsive to immunosuppression. You may be treating the interstitial abnormalities to increase the DLCO. You're obviously not going to remove the cysts, but the ground glass, the, shall we say, texture between the cysts, what you would hope is that you get a significant DLCO rise. And then you've established for the long term that immunosuppression of various kinds is crucial. Now, then you can nuance that and think about rituximab, other approaches, sure. But to be decisive at the first stage so that you know this is responsive, and don't go with an intermediate dose because you might miss a response. This is a bit like classic short course of prednisolone and COPD, but much more compelling. You gave some steroid to see if there was a steroid responsive element, and that seems to have become less often performed. But here, I think it's crucial to actually get a sense that this has a responsive element.
Thank you.
Okay.
Thank you. I will give you a follow-up on this, Asmita, in our future MDDs for sure.
Sure, sure. I hope my slides are visible now. Is it? Can you see the slides?
Yes.
Yeah. Go ahead, Dr. Madhu, all yours.
I think, Asmita, can you just permit Astra Mims Calicut to switch on the video? There is one.
Yeah, please.
Video, please.
Technical, Dinesh, can you please allow video to be on from that side?
Astra Mims.
Astra Mims. I think he can do by itself, no?
No, it's not permitted. They're telling. First has stopped it. Or if it is okay, I can just present my case.
Yeah,
Thank you and team for allowing. Actually, this is a young boy. The history is around 1 year. He's a 22-year-old boy who presented. He's a student from our nearby district, Kannur. Presented with a progressive dyspnea and recurrent infections. He complained of dry, non-productive cough. He was apparently healthy. He had a progressive dyspnea while going to gym. Next slide, please. So in March 2023, he presented with myalgia of around 1 week. He doesn't have any respiratory symptoms at that time. He developed these symptoms after taking an ice bath or something like that. And he was he developed some pleural effusion, which was aspirated. It was a neutrophilic exudative effusion with a low ADA levels. He was treated with antibiotic, improved, and they were discharged after that. So at that time, investigations were apparently normal except for mild anemia. Next slide, please. So again, he had symptoms in May. Every month he was having similar complaints of fever, cough, and dyspnea. He had bilateral effusion this time, which was aspirated, almost similar picture, hemorrhagic effusions, but lymphocyte neutrophilic predominant. Again, treated with some antibiotic and supportive treatment, improved. In September 23, he had a significant symptoms. He was admitted with a right lung pneumonia. He was evaluated at this time, found to have a RF factor positivity, but other things, ANA profile, ANCA, anti-CCP, everything was negative. He was started on steroids at this time and was continued on a lot of steroids. He was treated he was vaccinated at that time. We saw this patient in November 2023. At this time, they just came for a second opinion. He was on steroids. He was at that time clinically stable, well maintained. He has minimal exertional dyspnea, and the saturation was maintained around 98%. I repeated an HRCT and suggested, because there was no definite diagnosis at that time, suggested a lung biopsy and change of treatment, addition of antifibrotic, everything was suggested along with the myositis profile. He doesn't have any history of joint pains. He was a non-smoker. There is no exposure to pet or drug or occupational exposure. There is no history of asthma, allergy. He gives history of infections for the past 1 year. There is no significant history in the past. Examination was apparently normal at that time. Later when he came, he had a hypoxia and was requiring an oxygen at 3 liters per minute. These are later admissions. This last month admissions, he again developed the fever.
Can I interrupt here? I think, can we come to April later and let's just finish the scan so that people get a sense of what is the
Yeah. Just last slide, sir. April 24. So this is today, like.
Leave April 24 and come back to it after we've seen the scan.
Previous images? Okay.
The images are only of September and November 23. So why don't
Sure. Okay, sir. Yeah, fine.
I think that just makes sense. And,
Yeah.
So here's where we are. The lower row is the September 23. The upper row is the November 23. And at September 23, there was this extensive consolidation with ground glass, with subpleural sparing, predominantly on the right side. Also, a lot of changes in the left lower lobe, similar. But there is a background interstitial component that we can see. And if I just blow that up here, and you also have this row of cysts that has developed along the periphery, predominantly with upper mid zone. And we see a lot of these centrilobular lucencies, which almost look like centrilobular emphysema rather than actually cystic lung disease. So the question is, when you have a single row, whether you're dealing with paraseptal emphysema or not. And among other possibilities, this also could suspiciously look like hemorrhage within the lungs at this stage. Then you have 2 months later a scan where the lesions, the consolidation and the acute ground glass has regressed, but you have obviously this background ground glass with reticular opacities which are consistent, along with the paraseptal, single row of cysts that we see here, and these very subtle, centrilobular kind of lucencies within the lung. So this is the basic pattern. The mediastinum, etc., are completely non-contributory. The MPA diameter is a little high, but that's pretty much what we have. So this was September and November 23.
Yeah. So I'll go back.
Could I ask our radiologist if there is this subpleural sparing? Because I saw that a little bit. Of course, it is not
No, it is.
the classical one of NSIP, but just...
Yes, it's possible.
Because
I think
it is bilateral, yes.
It's bilateral. So there's been an acute thing in September, and then everything else is, especially if you see the first scan, there does seem to be a symmetry to the entire thing. So there is spatial and temporal homogeneity to the rest of the lesions. But the subpleural sparing in a way is a mirage, because you've got these paraseptal cysts, which are obviously they make it look like there's subpleural sparing. That's the other issue, whether there's true subpleural sparing, because you don't see it in the left lower lobe.
Yes, that's why I wanted to ask you. Yes, I was a little bit puzzled with that.
Okay. Shall I just finish the presentation and then we'll take the questions? Yeah. Okay.
I just interrupted so that we get context,
Yeah, Madhu sir, please go ahead.
Yeah, again, last month I was seeing him after November. This month I have seen him. He came with a severe pneumonia again. He was treated with antibiotics and he received one course of steroids in the hospital. His follow-up X-ray showed complete clearance except for the ground glass opacities and other things which is persisting. So all his basic investigations were apparently normal. All blood investigations showed only microcytic anemia. All RF factor was positive, but anti-CCP negative. ANA profile, myositis profile, ANCA, P-ANCA, C-ANCA, everything is negative. Pulmonary function was showing a restrictive anomaly. We don't have a serial PFT because I seen him last week when he was having a severe exacerbation. We didn't do that. And the only thing is he has a strong family history. His mother family, 7 members, 2 had interstitial lung disease. Mother had a rheumatoid arthritis and some respiratory failure. We are not very sure whether she also had ILD. He has 2 sisters. His sister is having rheumatoid arthritis, proven rheumatoid arthritis, but no significant ILD, and the patient is having ILD for the past 2 years. The question is, these are old images as Sir has already shown. The question is, are we dealing with this an young ILD? He has developed a significant interstitial pattern at the age of 24. So is it anything of a familial ILD? Or as he has a recurrent infection and following that some interstitial pattern, is it something of a immunodeficiency which is causing interstitial lung disease? or is it evolving CTD with a strong family history of multiple members having CTD? So we have suggested a whole genome sequencing anyway, and is sent the sample, result hasn't come. My question to the panel is there a role for lung biopsy at this moment? Should we continue with the steroids, add MMF, and somebody has suggested he should be on rituximab with a strong family history. So should we plan for a lung transplant plan or wait? Because of this a young age, we can't wait him to wait for a lung respiratory failure to occur.
So before anybody else goes in, I'm going to put my hat in here. We've got unexplained ground glass, septal thickening, acute exacerbation, cystic lesions. This combination at this age, one possibility when everything else is negative is surfactant-related disease. And I would really plumb for that and then look at the APCA genes and all of that in this genome sequencing to see if that's happening or not. Just that.
Okay. Yeah, I think we can start with. Yeah, please. Sir?
Related, can it appear in the late age?
Yes, absolutely. This is the classic age at which that little adult onset happens. So,
Dr. Jyoti, if I can start with you. So, because there is a strong family history of rheumatoid arthritis, all the family member has got rheumatoid arthritis. Do you think this boy is also having rheumatoid arthritis?
See, this RF positivity in ILD is well known. It can be very non-specific. And he doesn't have any clinical features to suggest rheumatoid arthritis. But since he's got a strong family history of RA, mother, sister with ILD and all that, cannot say whether that would be of significance or not. Anyway, he warrants, I think, the best bet would be, if you ask me, would be steroids with rituximab.
Fine. And our Professor Wells.
Can I?
Yes, please go ahead, sir.
I think his presentation at such a young age, which has started with fever, infection,
yes.
Pleural effusion to start with, which was hemorrhagic. Okay, and patient had developed a bilateral pleural effusion again. Okay, and the shadows which are there, like pulmonary hemorrhages. Okay, are we thinking about getting, first of all, before treating, we should try to get some diagnosis in him. So if the lung biopsy is not possible, why not a lavage? Can the lavage will be useful over here to get some diagnosis? Are we dealing with some parasitic infection, which can have some sort of similar presentation, especially in the tropical areas? So that's one which thought before we think about, just because of the family history of ILD is there, and collagen vascular disorder is there, why we are putting him into vasculitis, rather than some sort of infection which is leading into a pulmonary hemorrhage and some sort of that. So I would prefer to come to a diagnosis before putting him in any treatment.
Okay. Professor Wells and Professor Katrina.
Sir. I can't comment on a parasitic driver of this. I believe that you will actually have much more knowledge of this within India than I have from the confines of the Brompton Hospital in London. But first and foremost, at 22, with strong family history of rheumatoid and a strong family history of ILD, this is surely going to be linked. The family histories won't be irrelevant. So trying to call it something exact when you've got two family histories, and family histories often result in atypical phenotypes compared to sporadic disease, I would just say this is likely to be a strong familial element, and you might pursue genetic associations. But now let's think about the phenotype. There's microcytic anemia. There's an infiltrative process in the right lung which could easily be hemorrhage. The effusions were hemorrhagic. I like the idea that a vasculitic element is in place. Now, I don't want to be exact about that. It strikes me strong family histories of two separate predispositions, vasculitic elements. And so what do you say about the key decisions to make? One, with this lung function, I would anyway have him be talking to a transplant physician, because you don't know how this is going to go. So that is a good conversation to have, full stop. 2, whatever else you do, I'm sure that aggressive immunosuppression is correct, and if you think vasculitis is likely to be part of it, rituximab is appealing. I come back to surgical biopsy. I don't see this as high risk as it would be if you were dealing with a UIP element on the scan. I understand if you did a biopsy, you might find something called NSIP mixed in, but this is not an NSIP diagnosis driving this. It's just that you have to fibrose one way or another. The pattern might be NSIP. Your biopsy is to nail the vasculitis, basically. And so that's the decision to make here. And we're weighing benefit versus risk, but I've tended to go for a biopsy in cases like this. You've got to recognize you might miss a vasculitis. There's no guarantee you will get a specific diagnosis, but you've then done everything you can do to make a diagnosis, and then you're resigned to empirical management with the confidence of your lack of confidence, if you know what I mean. You then have to turn around and say, right, what could I miss that is dangerous? And the danger here would be undertreating an aggressive vasculitic element. I'm still holding fire on the parasitic argument. Maybe that makes you want to do a biopsy anyway.
Yeah. I would like to ask, if we have got Dr. Vimi Varghese, who is a transplant pulmonologist. So if we can just have a word with him also. Vimi.
Yes, ma'am. I think from what the history and other thing looks like, this familial component is definitely there, and I think it is worth keeping him on a follow-up with the immunosuppression. I think what Professor Wells told, and serially monitor, because the way he looks like he's a progressive phenotype type.
Okay, I think we are losing his. Yes, ma'am, Katrina, ma'am.
Yes, I much agree with all colleagues, and what Athos is suggesting. I think that we do not have to miss an opportunity with immunosuppression in this case. I think that I couldn't, say that pattern or phenotype. There is this, let's say, NSIP. Of course, it is not UIP, so let's call it fits a little bit with NSIP, I think, at the CT, but also it goes well with this up and down in these parasitic infections, or that we have some snaps and slots where the patient has unilateral pneumonias, etc. So maybe this also fits with immunodeficiency that sometimes is in a broad spectrum of secondary NSIP. So I would go with immunosuppression after checking to the blood for immunodeficiency in this patient.
Fine. Murli sir, or?
Yeah, so
yes, the transplant. Yes, the transplant. Yes.
So three sentences is all, because we're running out of time. First, I'd agree with all the diagnoses have been advanced so far. Surfactant deficiency, we've had a couple of patients when we've done the gene test, we found surfactant problems. Heterozygous rather than homozygous, so they take a long time to surface. I'd certainly do an immune workup, but I think a key would be to do a biopsy. You've got a window of opportunity, do a biopsy, and then jump in with as good treatment as you can. Refer him for transplant, because he's going to probably end up needing it someday if he does not respond to the strong immunosuppression.
I think that also a BAL with bronchial washes and extensive look of difficult infections and atypical mycobacteria would be also useful in this case, which is of course less invasive and would give us more information for infections, PCP, aspergillosis, etc.
Yeah, thank you.
I mean, so we will plan for if there is a window, I'll definitely go ahead with doing a bronchoscopy and try for a cryobiopsy if possible. At that time, he is slowly improving from his current exacerbations. After that, we have already sent the genetic analysis and immunological profile. So I'll get back if there is anything positive in the results.
Dr. Vimi has written, Madhu, that any therapeutic treatment option, if your genetic analysis reveals surfactant deficiency, then he would suggest even surfactant replacement also. And as we are running short of time, I'll just move on to the last case and
But
quickly.
before you run short, I mean, you move on. We're running short of time, but I can't help this. I'm just looking at Murli's background.
Yeah.
If that's a real background, your choice of book, my God, it is so amazing. I said, before we end and I don't get the time, I must say this, Murli. Amazing, So it is real, right? These are books that you're showing.
I was also observing. Actually, I saw it that it is not as
so
Zoom.
impressed.
Indeed. My dear Asmita, the levels of in serum of IgG are normal.
IgG, I don't think sir has checked or not. Madhu sir, was it normal? Immunoglobulins?
Yeah, I think I'll just get back to it. They have already done the results. Check. They will. I'll just get back to you.
He will find out and tell you. So moving on to the last case, and which is my case. And sorry for my ignorance if you find it very simple, but this was a 58 years old lady who was treated in Mumbai by my colleague Dr. Mehul Shah. And because she relocated here, she came here. So I don't know, it was labeled as asthma and hypertension and diabetes. She was diagnosed as COVID in 2 years back. It was a severe COVID, believed that. She was labeled as diffuse lung parenchymal disease with cor pulmonale. Oral antifibrotics were tried, but she didn't improve. Finally, she was started on inhalers and oxygen. So when she came to me, she had pedal edema present and her saturation was 88%, breathing 3 liters of oxygen. She denied any history of CTD, stigmata or any other complaint. Her ANA profile, 14 these antigens were negative. I did ACE level, which was negative. NT-PR3 MPO is negative. This is almost like March end. Myositis profile was done, which was negative. Because I just started seeing her, I didn't change any of her treatment, but she landed up to me in April last week, and that time she was significantly breathless. Her saturation went to 76%, and I have to admit her in ICU. That time she had audible wheeze. However, I felt it was rather than heart failure wheeze, rather than asthma wheeze, but that time her BNP was 9,024, was initiated on diuretics, and I had time to do CTPA at that particular moment. As you can see, she had uncontrolled diabetes. Her monocyte level was 10.6. At the time of discharge also, her BNP didn't come down. So with all this background and her FVC, which I could not do, but January Mehul has done, which was showing restrictive pattern. DLCO was hardly 15%. So this is a lady, 58 years old lady, without any significant past history, only 2 years history, everything post-COVID, labeled as a post-COVID, cor pulmonale. And I forgot to show one slide that was a severe PH. Anyway, my colleague Dr. Shine also has joined to say about echo. Over to you, sir.
Should I start the CT
yes.
or you do the echo?
No, yes, sir. Go ahead.
So we have a July 22 scan, which at that time was very characteristic of COVID-19 lung sequelae. You've got these curvilinear bands, some areas of sparing, some areas of air trapping as well, which may have been there from the beginning. But that's what we labeled her to have. Then in August 23, and I think I'll just show them together, there is an apparent increase, but in a way, it's just that the lung volumes have reduced. Her inspiratory effort was not very good. So rather than progression, it's just an apparent progression because the lesions aren't that, the lungs aren't that in the inspiratory phase. The lungs aren't expanded. Then at that time in August 23, she had a CTPA. You can see the MPA is a little dilated, but more importantly, the RV is large, the RA is large, the IVC is large. And there are lots of these lymph nodes, left supraclavicular, mediastinal, subcarinal. bilateral hilar as well, non-necrotic, that we can see. We'd seen them earlier as well and had mentioned them in the reports. And then at that time as well, the lungs, if you see, are pretty much the same. And the last scan, which is the recent one of April, again is expiratory. So you think there is progression, but there isn't. It's just that the lungs aren't expanded enough. Effectively, if you see the scan of April 24 and compare it to July 22, cross across, there isn't any significant change. It's as if you've got these COVID-19 lung sequelae, which have remained unchanged with a combination of air trapping, significant pH, and these lymph nodes, which could be just related to lymphatic congestion rather than being significant on their own.
Yeah, one second. So this is the current treatment. She is on diuretics, telmisartan, tadalafil, and I have initiated her on BiPAP because of her respiratory effort was too much. She can't breathe by her own, and she presented with type 2 respiratory failure to me. Shine has done echo. If Shine can just unmute and say what was your echo finding, and then we will move to Murli sir and our transplant physicians, what we can do about her.
Yeah.
Shine,
Yeah. Thank you, Asmita. I feel I am audible.
Yeah, you are.
Yeah.
Please.
So when Asmita sent this patient to evaluate any other causes for pulmonary hypertension, I couldn't find anything, but the echo was suggestive of very significant pulmonary hypertension. And there was evidence of RV dysfunction and some amount of right ventricular failure. So she was asked me as a cross consult was whether it was a possibility of an idiopathic pulmonary hypertension rather than a pure COVID sequelae. Echo-wise, like the heart was structurally normal. The striking clinical feature was the significant desaturation and the oxygen dependency the patient had, which is very unusual in a patient with idiopathic pulmonary hypertension. The two possibilities, usually what we see when they desaturate a patient with IPH, when they desaturate is the stretching open of a PFO with your right atrial pressures going up, or you have a low cardiac output and a peripheral cyanosis. So other than that, there is no reason why, without any heart defect, a congenital heart defect, somebody with an IPH should desaturate this much. And there was definitely some amount of, the significant amount of lung involvement. So IPH, I think, is out of question. We are probably dealing with something primarily with the lung.
Yeah, so that's what. So my doubt was first to Bhavin sir, that whether these GGOs were related to pulmonary hypertension or was it related to any? Because my doubt was, is there any interstitial lung disease existing? And should I start steroids if GGOs are ILD related? Antifibrotic she could not tolerate. Is there any point of giving it again? And as Shine answered, it is not idiopathic, then right heart catheterization is out of question. The family can afford transplant, but can we, with this much of pulmonary hypertension, will it be a good candidate? It's open for discussion. These were my questions.
So I'll just start out saying that when we first saw the scan in 22, I think we were quite clear that these are COVID-19 changes, that there was likely a COVID vasculopathy that had occurred, and the pH was probably related to the underlying lung/vasculopathic changes, because we'd seen quite a few of those. And we used to actually do dual energy scans. Sujit will remember. We did a series of about 25, 30 patients. We should have written that up, where we saw all these perfusion defects that were first described by Remy Jardin-Martin from France. And we've seen some of them improving, but some of them don't improve. And probably this patient just has that, but open for discussion.
Yeah, Murli sir.
Dr. Shine, before how was the left heart? How was the left atrium? Was there any evidence of diastolic dysfunction?
No, sir. There was no evidence of diastolic dysfunction. I had specifically looked into that. The left-sided chambers were fine and normal function. Basically, the RV was hit.
And did you do a bubble contrast? No. You mentioned the PFO.
Yeah, no, I did do a bubble contrast, but the image was good enough that I could feel there was no significant shunt across the septum. The saturation of 76% on room air, I should have expected a lot of shunt happening, which should have easily picked by a Doppler echo.
Okay.
Prahlad sir. Yeah, Murli sir. Yeah.
Yeah. So, I would completely agree with, we are dealing either with group 3 pulmonary hypertension, but I think it's certainly worth doing a ventilation perfusion scan or looking at a repeat CT and doing the dual energy. Vimal will tell you
I'm sorry to interrupt you. I think VQ scan was done. I didn't mention it. Mehul has done VQ scan, and he was thinking of CTAF at that particular moment, and he could not do CT pulmonary angiogram because of some reasons, and that VQ scan ruled out CTAF. That's what the report was showing.
So the possibilities are a small vessel vasculopathy, but I would still go with this degree of lung involvement to a group 3 pulmonary hypertension. And perhaps, I don't think this idiopathic pulmonary hypertension, the arteries don't look like that at all. I think Bhavan is, ruled out group 4. So really we're dealing, I think, with the group 3 pulmonary hypertension. Treatment would really be oxygen, BiPAP as you've started, and prepare her for a lung transplant.
Yeah.
We have seen similar patients in COVID times here also. And I feel this is some sort of an COVID-related pulmonary hypertension. Okay,
yeah.
The lung involvement doesn't look so extensive to cause basically lung-related pulmonary hypertension per se. So COVID vasculopathy, or probably some sort of a thromboembolic pulmonary hypertension. Probably we have missed the DVTs and thromboembolism that time. That is a possibility.
Yeah, Professor Wells.
I like COVID as a unifying driver of this, but I would separate the more acute pneumonitis and the after effects on CT, and what we're struggling to understand in all its manifestations, which is the longer COVID consequences of COVID with a thromboendothelial phenotype, small vessels involved, evidence of immune hyperresponsiveness a year later in the Nature paper that came out, and these unusual vasculopathies. We have a string of patients with low DLCO that's getting worse post-COVID a year or longer down the line, which we're trying to get our heads around. And I suspect here that you've got a more acute COVID consequence on the scan, and you may have a long COVID pathway in operation in the vessels. And how you tease out that it's all secondary to the lungs, or it's all or mostly driven by a vasculopathic pathway related to COVID, I don't know how you can do that. I have enough trouble separating secondary pH from non-secondary pH in ILD in general. And I think in this context, where you may have 2 COVID pathways in operation, I'm not at all sure how you can classify this either way with confidence. So I suspect COVID is the unifier, and that perhaps you're getting a vasculopathy, which is a long COVID manifestation on top of a more acute post-COVID damage consequence. But maybe you can debate the interstitial abnormalities and view them as long COVID as well. I don't know.
Yeah, so Madhu sir is telling that can we do PET CT because the nodes are significant, and I don't remember, sir, Bhavin sir, but was our CT scan which was done in April last week was also showing the same amount of lymph nodes?
Yeah, but the lymph nodes haven't changed. So
okay,
say from July 22, 23, about 18 months, they've remained the same. So, and so sometimes we do get nodes as part of the underlying, PL/cardiac problem. And if they're not changing, perhaps they're not really that significant.
Any chance of sarcoidosis being a possibilities?
I mean, it seems unlikely given the way things are. The lung changes don't look like sarcoid at this stage for sure. And again, little circumstantial evidence about everything started only with COVID.
Yeah, that is what it is. And 1 or 2 questions that hemosiderosis or BAL HSP. I earlier diagnosis was hypersensitivity because of GGOs, but Bhavin sir, you do not feel this is a hypersensitivity at all, right? Well, it is COVID.
If the patient had presented for the first time today, we would have considered that possibility for sure. But, or let's say I presented in the pre-COVID era, we would have considered that possibility, but not with all this happening.
Yeah, Apar, finally, our transplant physician.
Can I just come out with 2 things? One is Deepak Gopalan had a paper, I remember, during the COVID pandemic talking about SPECT in these patients with this small vessel vasculopathy. If you can get it done, that's something to consider. That picks up these small subpleural patchy changes, which will then push you more towards this kind of condition. And the second question is, would she benefit from hiking her the pulmonary hypertension medication gradually? So push
we are planning, Shine, we were planning, right?
Yeah, we are planning that. As you know, sir, there is no strong data favoring pulmonary vasodilators in these subset of patients, but we have started for whatever benefit it is.
Yeah, so I thought we could monitor carefully and push it up gradually. If she worsens, bring it down and treat her as group 3 only. And consider whether some form of anticoagulation may help if you're dealing with small vessel vasculopathy. Extremely controversial.
Docs, apixaban kind of, or you want?
Yeah, either one of them is fine. I don't think.
Fine. Okay, Apar, your comments. She's 58. Her lung function 15% DLCO, her severe pulmonary hypertension to the amount of, I think 70 plus RVSP kind of. Yeah.
From the indication standpoint, even though this is not a progressive fibrosis as we've seen on the scans, it is a sequelae from the COVID and the fibrosis is stagnant, but still the lung function is quite poor. And the patient is already in severe pulmonary hypertension along with right heart dysfunction. There is an enlarged RA, there's an enlarged RVA with a dysfunction, which we could see on the echo. So she not only classifies into the indications for the transplant, but she also fits into the listing criteria if we take it as an ILD with pulmonary hypertension to be listed for a transplant. Now, from the perspective of is she an ideal candidate or not, she is a candidate for transplant per se. But then we need to work this patient up. She's 58. We need to look at what these, muscular skeletal parameters are. She has had multiple exacerbations. We need to look at what the sensitization status is. We need to look at her HLA and the PRAs. So apart from those angles, and then looking at the GI system, that, how much of reflux is there as part of the disease, and, how much of the GI system is also involved. So a full workup from the transplant perspective is indicated at this point of time to establish whether she is a good candidate or not. But yes, she definitely is a candidate for lung transplant and would definitely benefit from one.
Okay. I think any comment from Professor Katrina, and I will just wind up.
What's her PCO2, Asmita?
Sorry, PCO2 at the time of admission,
currently?
I'll just tell you. One second. If I have not put ABG, I may not remember, sir. I'll get back to you, sir.
No problem. If it was just rising, then the transplant is obviously more imminent.
Yeah. Sure.
Yes, I also think that I don't have a lot to add, unfortunately. Of course, I would go for these options, and of course, let's say the preparation of the patients for a transplant with all needed pH assessment, PCO2, exercise, etc., would be ideal. And I think it is a very, a case which it is emerging to discuss multidisciplinary in order to take decisions. It was a difficult case, my dear Asmita.
Yeah,
so
I know.
I think, I think it is, very well that we have discussed it here.
Yeah.
It was nice of you to apologize for this being too simple at the start.
Yes, but I think sometimes
high priority
is
for
needed.
transplant. High priority.
Yeah,
is
me too.
I was thinking it was a very stupid question to ask whether ILD exists or not, because I was confused about the ILD existence part. I was thinking it is pure pulmonary hypertension, because we have not seen COVID related this kind of changes, sir. Somehow, we see fibrosis, but just COVID causing severe pulmonary hypertension, I think this is, sorry to say, but first time I have come across.
What is confusing here is that probably the pH is
ABG PCO2 was 23.9 at the time of admission, and then it was 34. So PCO2 was never high, and I believe that the BiPAP was started for the support of a respiration effort rather than PCO2 was not indicated. It was always fine. Yeah, hypoxia is the predominant problem. I think that's it today. We we shoot around 15 minutes more than our usual time, but it was difficult cases.
You did 4 cases.
And it was the last one.
4 cases.
4 cases,
And
we
first 2 got over in 30 minutes flat. So 33 minutes. That was great. So,
yeah, we did a good job, and thank you so much, all my dear faculties who took their time to come here. Professor Wells, Professor Katrina, Prahlad sir, Shine, Madhu sir, Murli sir, our dearest Bhavin sir, Jyoti madam, Rajan sir, Vimal Raj sir, if you are still there. And today I didn't take the picture also. If you people will allow me to take, I will take.
I think this is a very nice multidisciplinary idea that maybe next year, next academic year, we can organize with European, let's say, support and other colleagues from Europe, and why not also Latin America and US. So we can have a series of webinars with cases all over the world. I think we did very well. And I think that your participants enjoyed discussions and difficult cases and difficult decisions regarding treatment and management. And it was a very nice idea of being all together. And thank you for this opportunity to participate. Lovely.
Thank you so much. Thank you all the delegates who have joined here. And today I was able to take some chats also. So we'll try to incorporate audience questions, so they also should feel part of it rather than be only discussing. Thank you so much.
Yes, indeed. Why not? Yes.
Yeah. Thank you.
Thank you, Smita.
Yeah, the next meeting is on, I will like to say that is on 24th of May. And the pediatrician are available only for June, sir. So I think we will have our adult meeting only. The pediatrician, my pediatric rheumatologist is convenient time is only on June. So the next meeting will not be pediatric case, which I have already shared with both of you, but we will be dealing with other cases.
And Vimal will be the lead.
Yeah, I know. Bhavin sir is waiting to say that. Yeah. Okay.
Okay, great.
Okay, we had a great time. Thank you so much.
Thank you.
You all.
Thank you.
Thank you. Bye. Good day.